So coming to the etiologies, if you think that etiologies, as I said, most of the times it lights in the coronaries, plaque rupture or plaque erosion are most common cause, vasospasm, SCAD, and in situ thrombosis, which may be thrombolized spontaneously. And there may be, of course, there is a one etiology like a thromboembolism. The source of embolism can be LV or LA, which is valvular vegetation, which is embolized into coronaries, can cause microvascular obstruction and presented like a MINOCA. This is the one thing, coronary microvascular dysfunction. It can also cause the MINOCA type of presentation. And some non-coronary cause, as we know, always when there is a imbalance between the supply and demand, sudden blood loss can not sufficiently sufficient enough to supply the myocardium, can cause infarct, and sudden hypertension, respiratory failure with severe hypoxia also can present with infarction along with the tachycardia and bradycardia where perfusion is not enough to reach the endocardium. So this is one condition. I said Takotsubo cardia, don't mention like a MINOCA, because after first you can make it as a working diagnosis, but after doing LV angiogram, Takotsubo is not infracted, it is a myocardial cellular injury, so you can rule out by doing LV angiogram and MRI. So if you are suspecting MINOCA, how do you approach that? You are suspecting acute coronary syndrome, then do coronary angiogram. If severely CAD, obstructive CAD means generally you revascularize a goal-directed medical therapy. If it is less than 50% or not severe enough, then don't label it as completely as a MINOCA. Just go back to angiogram again and try to see carefully. Sometimes you may miss some diagonals. If you are seeing two diagonals, you search for in between, maybe you are missing one more diagonal, or sometimes you may miss the OMs, which are not visible in routine angiogram. If you are in doubt, you can give NTG injection. If some vasospasm, which is masked by vasospasm, it can be unmasked by the NTG. And do LV angiogram. LV angiogram can sometimes needed to exclude the this Takotsubo cardiomyopathy. So when everything is okay, then you may evaluate like a MINOCA. And if lesions are borderline, as I said, evaluate further with IVUS or OCT imaging. Alternatively, after that, or you can go directly to the MRI sometimes. MRI especially helps in this type of condition to rule out the subendocardial ischemia, and also it helps to rule out other conditions, mimickers of the myocardium. Like MRI is a very important tool for confirming the MINOCA by giving the diagnosis of subendocardial ischemias or infractions, along with the ruling out of myocarditis. In myocarditis, that is cellular injury, cellular edema, and pericardial involvement, along with the pan-myocardial involvement, non-respecting non-coronary territories. By some indication, we can exclude other diagnoses. If everything is okay, then you want to test for, you are suspecting vasospasm alone, then you can do provocative testing with acetylcholine for vasospasm, and you can rule out the vasospastic related infraction. So this is LV angiogram, which is showing a typical of Takotsubo cardiomyopathy. And here IVUS, see, the coronary angiogram in this case appears to be normal in this infracted case. But if you do IVUS, see in this place at the 11 o'clock position, there is a plaque rupture. And with MRI, we have confirmed in LAD territory, there is a apical septal which is showing a late guided enhancement. So that gives the diagnosis as a MINOCA at the end. So similarly, OCT showing borderline RCA with in coronary angiogram, but by doing OCT, you are seeing a big plaque rupture here. That is a culprit for MI. So this is, I want to say one interesting clinical scenario here. One patient with a paroxysmal atrial fibrillation, not on anticoagulants, presented with the chest pain, has showing rising of falling of troponin I levels with no RW MI. And upon further evaluation, so angiogram appears to be normal, but MRI showing typical of focal infraction area, suggestive of embolism a cause for infraction, and we started with the anticoagulants in that case, not with antiplatelets or anything. So it has helped to confirm the diagnosis and planning the proper management and proper treatment. So these are the other images of OCT which are showing different pathologies. So then the testing of vasospastic angina can be done with acetylcholine, and microvascular circulation, of course, it may be the cause of MINOCA. So it can be tested with a non-invasive model like PET CMR, and invasively the two parameters IMR and CFR, IMR of greater than 25, CFR less than two can be, say, like a microvascular dysfunction, and it can be done with the Abbott vascular system, where it can give automated values with two pressure sensor at the end of the pressure wire, which calculate automatically and give the values. This is the picture where vasospasm is suspected after giving acetylcholine, first normal luminal diameter, but after giving acetylcholine there is a diffuse vasospasm, and treatment of choice for that is GT and sorbitate and that. So vasospasm, if you, after doing perfect analysis, according to the cause, we can treat vasospasm after suspected calcium channel blockers and nitrate. If microvascular dysfunction, beta blocker, calcium channel blocker, embolism suspected mean anticoagulation. According to pathology, plaque rupture mean DAPT and statins, etc. We can consider and plan treatment according to pathology. So coming to the MINOCA. MINOCA is the same thing, it's like a, INOCA. INOCA is ischemic. Some patient presented with ischemic symptoms, exertional angina, you do TMT, it's positive, or stress test, it is positive, but you are doing angiogram, it's absolutely normal. Then you suspect this condition. It is quite common condition. The causes are coronary vasospasm and coronary microvascular dysfunction. It is common in 70% of the female and 30% of the time it's males. It's not a benign because impaired the quality of life, repeated revascularizations, hospitalizations are needed, and a lot of healthcare costs. So the who are more prone, definitely women are more prone, and traditional risk factors are not well established, and non-clinical risk factors like estrogen fluctuation, inflammation, genetics, migration are proposed mechanisms. Similar testing as like a MINOCA microvascular testing is needed, and confirm the diagnosis with the diagnosis is needed with the testing. And if you know the cause, then you manage with the lifestyle risk factor management like hypertension, dyslipidemia, diabetes, and anti-anginal medication, beta blockers, calcium channel blocker, nicotinic, anosine, ivabradine, and trimethoprim can help. The take-home message is common. Up to 70% of patients undergoing coronary angiogram do not have obstructive CAD. It's not benign because it's associated with the cardiovascular event and repeated hospitalization and impaired quality of life. Often misdiagnosed, under-investigated, under-treated. Main mechanisms, as I said, coronary vasospasm and microvascular dysfunction are the causes. Objective is to assess a need, and stratified personal treatment can be given as per the cause. So, thank you.